Well, good evening, everybody. Welcome. If you're new to Legacy Community Church, no mai haere mai, welcome. I'm Nigel Ripley, lead pastor here. And this evening is a question and answer session with our guests from the CDHB. And I want to thank our guests this evening for making time for us. Some have come straight from work, and as you can imagine, in a pandemic, on top of everything else health-related, they're very busy people at the moment, and maybe for a little bit more time to come. So we really appreciate you giving us time, and Dr. Satish for helping pull this all together for us, who's been my main contact at CDHB and very helpful. We've already had with some of these clinicians a Zoom meeting for church leaders, and there's a really helpful time of Q&A, and so we've been able to piggyback on that and steal them away for a bit more time. So the aim tonight is to provide people direct access to some of the lead clinicians responsible for preparing and leading our local health system for when COVID-19 arrives in Christchurch. They aren't politicians, and they can't answer for what Cabinet discusses behind closed doors on Mondays and whenever else they meet. So I would describe our guests as the meat in the club sandwich, the ones who get stuck between politicians' decisions, the public's decisions, the science of viruses, and the actual real-time realities of people getting sick and dead. So with that in mind, can I ask that all questions relate just to the biological aspects of the pandemic, not the political issues? So relating to things like viruses and vaccines would be great. So if you would like to ask a question, can I encourage you to, or if you've got a political question, then you might want to see me about whether we can get in some politicians and you can pitch some questions to them. Actually, there is a meeting of church leaders with the local MP tomorrow via Zoom. So we are actually pitching a few things back. So, but tonight's really just about the pandemic in terms of viruses and vaccines. And our guests have generously given up their time to answer any questions that you may have had over the last couple of years. And we want to encourage you to confidently ask those questions. We're going to have a microphone so you can ask them and be heard clearly. And I want to thank again these doctors for their time in helping us on this complicated pandemic journey, which none of us here have been on before. So what I'd just ask, maybe if you could introduce yourselves and your role and expertise, and it'd be really helpful to get to know who we've got on the panel tonight.
Sure. So my name is... Hello everyone. So my name is Satish. My role in the vaccination program is with the actual implementation of the actual vaccine around Christchurch and Canterbury. So I'll be able to answer questions about the process, the operational side of things, and the implementation.
Kia ora koutou, my name is Claire Salter. I'm a public health registrar. I'm working in the vaccination program in the quality improvement and evaluation for disability team. I used to work at the public health unit doing case investigation and contact management before this.
Thanks, Claire. My name is Alan Pitty. I'm a consultant physician at Christchurch Hospital. I'm the DHB's clinical lead for COVID. I am involved in the vaccine programme, but also all other aspects of care, particularly planning care of people for COVID, that kind of thing.
Hi, my name is James Yu. I'm an infectious disease and general physician as well, much like Ellen, and I'm also helping out with the hospital's COVID preparedness work, basically.
Good one, thanks for that. I just thought it'd be great to get some context. So if you're able to maybe update us on sort of the current case numbers in New Zealand, and how does that compare to what's happening internationally regarding this pandemic?
Shall I do that? So New Zealand's in a really fortunate position. Sorry, John?
Put them up.
Put the numbers up.
New Zealand numbers, yeah.
Yep, shut them up. So we're in a really fortunate position, New Zealand, compared to most other countries. This is actually just as of today. I just got these from here, and we can see age, a breakdown by age. A total number of cases we see 8,700, and the cases who have been hospitalised overall is 457. So that is about 5% of people. So that compares, obviously, if you compare to other places, for instance, New South Wales has just gone through a big epidemic, as everybody knows about the Sydney epidemic. They've had about 70,000 cases since mid-June, of which about 10% of their cases, 7,000 people were admitted to hospital, and about 700 people ended up in intensive care. So it's really quite easy for New South Wales to do the rules of 10. We've had a lower proportion of people actually admitted to hospital. It's important that, do you want to show the next one with the vaccine? We're really quite lucky, and I think we'll just start with this really, is that we're fortunate because what we're seeing is vaccine effect, I think, in reality. And what we're seeing is here in the top one is just showing you the number of people who, well, actually, the best way to do it is, so the best way to do it is to look at this, and at the bottom say, no doses received prior to being reported as a case, and cases who were hospitalised. You see that most people who were hospitalised, 295 people, had actually not had any vaccine. About 100 had had one dose, or had had perhaps second dose within a few days of being admitted. And actually very few people had actually been fully vaccinated, 29. The non-eligible are children less than 12, of which there's been 37 admitted to hospital. So the vast majority of people, in fact, are unvaccinated or have not been fully vaccinated admitted to hospital. And that's exactly the same as what's seen in New South Wales. Of their roughly 70,000 people who have been infected, have been diagnosed, I should say, with COVID since June, about 12% have been fully vaccinated. But when you look at hospitalisations, it's 6% have been fully vaccinated. When you look at intensive care admissions, it's less than 4% are fully vaccinated. So we're seeing this effect throughout. If you look at my home country, the UK, 130,000 people had died from COVID before the vaccine was introduced. Since the vaccine has been introduced, it's been about 10 to 15,000, so a tiny fraction, although it's been much longer. So overall, it's worked out that vaccines prevent about, initially after receiving them, they prevent about 3/4 of infections. They prevent at least 10-fold admissions to hospital, between 10 and 30-fold, depends where you look. And they do very similar for reducing mortality death rates. You're looking puzzled.
No, I'm just thinking.
I like your T-shirt, by the way.
Thank you very much. No, I'm not puzzled. Just...
So, I mean, wherever you go and you look at, from our point of view, the kind of statistics that we look at, there's a dramatic vaccine effect in preventing people being hospitalised and preventing serious illness. It's actually quite rare to see people who are fully vaccinated being admitted to hospital and getting sick. And those who are fully vaccinated tend to be very elderly and tend to have comorbidities, i.e. serious medical conditions. Just finally on this, we do know that the vaccine loses the effectiveness a little bit after about 6 months, and Israel's done an amazing study when they took people over the age of 60 who had been vaccinated 6 months before, and they were given the third dose, the booster, and they recorded a 10-fold drop in hospitalisation and a further 15-fold drop in serious outcome. 15-fold. So it was a dramatic thing. And in fact, you have got one slide there which actually shows this is, I'm doing all the talking, I'm going to stop after this one, so let everybody else talk. But this is an interesting slide because this is from the UK, and I think it's really helpful. It's not talking about hospitalisations, this is talking about people getting COVID. And so the dotted line across the top at 25% is the unvaccinated group. So during that period of time, 25% of people were getting, you can see, we got infected. After one dose of vaccine, it dropped the rate to about 15%. But after 2 doses, as the blue line is the Pfizer vaccine, which we will talk about, which we have in New Zealand, drops it to about 2%. So from 25 to 2%, that's more than a 10-fold drop in people getting infected. Then what we know is that the vaccine does fade a bit over 6 months, but it's still only got up to 10%. And then after the booster, it's taken it way down to virtually 0, actually. So the booster is incredibly effective, and that's what we found in Israel. Does anyone else want to add anything to that? So we just take
That's
questions.
from the UK.
That's UK data, yeah. So that's UK data, yeah.
Can you maybe just tell us a bit about what's been happening in Auckland? We're so disconnected from the reality in there. What has it been like for the hospitals and the impact of COVID in Auckland?
Yep. Shall I talk about this? Okay. So we've been talking to our colleagues in Auckland quite a bit in the last few weeks, to be honest. So it's been quite sad, really. They've had a lot of very sick people being admitted to Auckland Hospital, Middlemore, and actually Takere. Up to about 30 people at a time. A third of people have had to go onto what's called CPAP, which is assisted ventilation with a mask giving pressure. Another third of people have had to have what we call high flow, very high inflation pressures of oxygen. And the other third have been on low flow. Most of the people have been unvaccinated, and all of the people who've actually died and come to harm have been unvaccinated. And there's been a couple of people you've seen in the press recently come stories about the 59-year-old man who was the rugby league player, and then the 80-year-old man who was the journalist, and stories have actually come out about these individuals in the last couple of weeks. So, you know, of the people who have died, they've all been unvaccinated. There was one man in his 50s, there was I think somebody in their 40s as well. Most people who come to harm, to be honest, are older, but if you happen to have a lot of other complex medical conditions, you're likely to end up in hospital also.
Good one.
So we might take questions, eh?
Yeah, what we'll do is, Mana's got a mic at the back there, so if I could actually get people just to queue up behind the mic, and that way we can actually get people, make sure everybody gets a fair crack at asking a question. And what I'd like to do in terms of question asking is, if you just ask one question, it's not a preach time, so Sunday morning's for preaching, tonight's just for questions. So if you've got a question, ask them the question, and then after that you'll get a chance to do one follow-up question, but just the one, and then the next person can have a go. And that way everybody gets a good go at it. And if you're a slow processor like some of us are, and you're thinking, I've got a question, I haven't quite figured it out, you'll have a bit of time to actually do your processing and then ask the question later on as well. But if we've got time for more questions and you've got more questions, then by all means we'll be able to do that. So you'll know, because there'll be a wee queue there and you can just jump on behind that. So the mic's open at the back there. Just go on up, ask your question, and remember you get one follow-up question as well. Good on you, Martin.
And just to say, we're happy to have a stab at most questions.
Hi, I was just wondering about the booster vaccination. So after 6 months, so do you see, or is there data around when if another booster is required? So, I mean,
No,
how long would it last for?
Makes a lot of sense. Yeah, we don't know this is the bottom line, but we do know that from normal immune responses that after one dose you get a limited response, after 2 you often get a better response, and after a 3rd dose you're more likely to get a more prolonged response. But what we don't know, we just don't know yet. There are a few variables here. This virus tends to mutate, as we know, and there might well be that might be another factor. We are fortunate because all of this is going to happen in the Northern Hemisphere, and we can just follow on, to be honest. Whatever's happening in the US, the UK, Israel is way ahead from the vaccine program point of view. Does anyone else want to add anything?
I was just wondering if in the event that I actually get COVID and recover successfully, does that in fact bring it behind some sort of natural immunity which is equivalent to the 3rd dose? Do we know that? Or do people are likely to catch it again and again?
Well, no, we do know that. Let's answer that.
Start. We do know most people, not everyone, will get some antibodies, some natural antibodies to infection, but we do know that it's not as good as if you've had the vaccination. It's not as strong, and we do know, as it shows here, that the vaccination does wane a wee bit. The same for natural, will wane if not more, and we know it doesn't give you as good a levels. So we do encourage, if people have had the COVID infection 4 weeks after they've recovered, they're advised to have 2 doses of the Pfizer vaccine in New Zealand.
Yeah,
so then they've got
this was more in the line that, you know, I'm double vaccinated already,
oh, yeah.
and then if I do get an exposure, does that give me the equivalent of the 3rd dose, or are you saying that the 3rd dose is still the best thing to do?
Say yes.
The absolute answer is yes, to have the 3rd dose. We just don't know. I think, to be honest, it's very likely that if you are exposed, then we know that people who are vaccinated do get infected. That's very clear. And it's very, very likely they will do degree of protection. That we just actually, I'm not aware of it. Are you aware of any data to actually say, to answer that question? Yeah, James is.
So I think we don't have data around that. The key thing to remember about this pandemic is things keep changing and new information keeps emerging. So what we say today may be wrong tomorrow and many months down the track. And that's what we found. You know, we've come a long way, I think, scientifically, you know, from masking, from vaccination, from understanding of transmission of viruses over the last year. So, you know, these are good questions, but we don't have answers for them. But if you look at other infections, there's this thing where not all infections are actually, you know, as in, how should I say it? We have this false impression that any immunity is 100% protective for the rest of your life. And I think that comes from the fact that we have such good vaccines with measles, mumps, rubella and all that. And people think that it's got to be 100%, otherwise it doesn't work. But most of the vaccines actually give you partial immunity. And most of the time, if you get an infection, you don't form full immunity for the rest of your life. So if you look at some of the things, some other infections, for example, malaria, for example. So if you work in Africa, you've been a missionary out there or did some work out there, you realize that all the kids who die from malaria, all the people who die from malaria, severe malaria, are kids, children. The ones who die from typhoid, they are children as well. The adults don't really die. They get sick, they get fever, they get like a bad flu, they're off work. And why is that? It's because the people who have grown up in that environment, they keep getting what we call natural boosting. They get subclinical infections with malaria, subclinical infections with typhoid, and they build up an immunity. That is not protective. It doesn't stop them from getting infection, but what it does is stops them from getting sick. So immunity, see that as a continuum. There's 100% protective, and there's also protective against severe disease and death. The same with COVID. I think what will emerge in due course is that your immunity will wane, even though it's natural immunity. You may still get subclinical infections, and who knows what the future holds. Maybe it will become milder and milder as we build up more immunity and we get natural boosting because the virus circulates. Who knows? If we become like a country where the virus circulates widely, like in Singapore, where they were getting 5,000 cases a day, everyone will get a turn at the virus. But the key thing is not to die or become very sick from the virus. So the vaccine gives you that first layer of protection and stops you from getting sick, but then allows you to maybe get exposed to it naturally and hopefully not suffer severe illness from that. Does that sound reasonable?
That's incredibly reasonable.
Yep.
Just to add, although you can see it, your initial immunity to getting infection wanes a wee bit, the chance of getting hospitalised or dying wanes a lot less. We've seen in studies from overseas. So the chance of getting an infection goes down a wee bit, but your protection against severe disease doesn't wane as much, which is really important.
Okay, I think you may have just partially answered. It was more of a clarification perhaps than a question. But I do thank you for coming out tonight, because it's been very confusing for me and maybe others. There's been a lot of information out there and disinformation maybe even from both sides of the debate. So to be able to come here tonight is awesome. But the point of clarification I was looking for, because you've just mentioned, and before your colleague, was around the drop-off in effectiveness. And I think and on state news, even within the last week, I thought I heard down to perhaps even 43% effectiveness after 6 months on the state news. So that's why I got up here to seek the clarification, and you've already touched on it, but yeah, be interested to hear.
it's very clear that the vaccine loses its effectiveness at preventing infection, but remains very effective at preventing people, stopping people getting sick. So that's very, very clear. Singapore is a really great example, because Singapore has got very, very high vaccine levels. They are seeing quite a lot of infection, up to 3,000 cases a day. 98.4% of all their infections are either mild or asymptomatic, in fact. Now, if you compare that to the first wave of COVID, when there was not vaccine, we know that all of the hospitals in the Northern Hemisphere were overflowing. They were just could not cope. My colleagues in the UK, I spoke to my old colleagues in Glasgow and things, and they just couldn't cope with the volumes and numbers of sick people coming in. That's completely turned on the head. So there's still large numbers of people being diagnosed in the UK. And I had a chat with my daughter who lives in London the other week there, and she said, "You know, there's lots of people get diagnosed, Dad, but actually nobody's sick anymore, you know, unless you're unvaccinated." Unvaccinated people still get sick at a rate of at least 10-fold increased risk, often up to 30-fold. Yeah.
Thank you.
Yeah.
You mentioned the use of respirators. If someone gets sick and hospitalised, they may need to be on a respirator. Is this a good time to ask, what can an infected person expect if they are hospitalised in terms of their treatment?
Yes, I think so. We can have a go at that. So a proportion of people would obviously get hospitalised, and the major reason why people would come into hospital would be shortness of breath. Virtually all of the people who were presented and admitted to hospital in Auckland came in short of breath, difficulty breathing, and fever. Most of these people almost immediately have to go into some kind of oxygen support, given a mask and oxygen like that. A third of people, that's okay, that's all they require, and these are hospitalised people, and that's all they require. Of the experience in Auckland is that another third of people had to go on to what they call high flow, and that's much, much higher pressures of oxygen through a mask, and they were also asked to lie on their tummies and be nursed on their tummies, what we call proning, because we find that that's a more efficient way of breathing when you're very short of breath. And the worst third of people would end up going on to this supported one, which is pressurised oxygen. Not invasive, not with a tube down your throat, but just a very, very tight-fitting mask. We call it CPAP, and that's quite unpleasant. And most people have been on that for about 4 or 5 days before they can be weaned down to the lower level. So a lot of these, some people, a small number of people come in and they're out in just a few days because they're quite mild, but quite a significant proportion of people end up in hospital having these treatments. And about 5% overall will end up, of those group, will end up going to intensive care and having to have a tube put down their throat into their lung to help them to breathe. That's actually very bad in COVID. If somebody ends up that happening to them, then they tend not to do very well. So that's generally it. The people who are at greatest risk are obviously older people, as we explained. You know, if you're over 80 and you happen to get COVID, you've got about 20% chance of dying. If you're 70 or so, it's about 5 to 10%, James, isn't it? Yep. And if you're about 60 or so, it's about 1%. But if you've got comorbidities like type 2 diabetes, if you're quite overweight, all these things feed through to having a much worse outcome. Does that answer your question?
Do you do anything else?
Oh, can you do things? Yes, you can. So there's some new treatments available. And you might have heard of some of them. You can have injections of a steroid called dexamethasone. You can have an injection of what's called a monoclonal, goes by the name of tocilizumab. And they do have a dramatic effect at improving outcome.
Is there a steroid inhaler?
The steroid inhaler is only effective for people who've got minor symptoms in the community. So that's early on. So if you can make an early diagnosis of COVID, then you can give the people a steroid inhaler, and there are some new drugs you might have heard of called molnupiravir, which is almost certainly going to be available in New Zealand probably early next year, but it has to be given within the first 5 days of symptoms. It's no value once people become unwell or beyond 5 days. So yeah, there's big advances actually coming through now, and there are several new antivirals which are going to be improvements. None of them are actually as effective as vaccinations.
Yeah, James is the expert in treatment.
Not really, no. I'm just going to add to what Alan's been saying. I think key to understanding what happens in terms of treatment is what happens with the virus. So different bugs, different pathogens cause damage to your body differently. Some cause trouble by attacking your cells. Some actually cause trouble because your immune system overacts. And COVID is one of them actually. So for the first say 5-7 days, it's actually just the virus replicating in your body. But what happens in some people, and those people who are at risk, meaning the elderly or people who have comorbidities like cardiovascular disease, overweight, etc., is that they have an overactive inflammatory response. So when that kicks in, it actually causes massive damage to your lungs, to the rest of your body, and that's when the real trajectory downwards happens. And once you get into that trajectory, it's very difficult to pull them back, except using stuff to suppress the immune system. Hence, we are giving steroids. Tocilizumab is actually a drug that suppresses the immune system. It doesn't make sense initially, isn't it? You're giving stuff to suppress the immune system when you've got infection, but it's because there's been overdrive of the immune system that's causing damage instead of helping. So all the antivirals that is being publicized in the media has to work within the first few days to stop the virus numbers from building up before you reach that stage. Hence, that's a difficulty because you may not realize you have an infection until it's a bit too late. Hence, Alan's point is that why not prevent it rather than try to go through the whole process of dealing with the infection itself.
Yeah, so that's one of the things that people are looking at in the community is monitoring people's oxygen levels, because that's one of the main worries, is that people's oxygen levels dip down after if they've been unwell for a wee while, a couple of weeks, their oxygen levels can dip down. So monitoring people's oxygen levels is one of the important things for watching if they see a big change to jump in there.
Yes, you probably touched on it a little bit, but we've had some very interesting discussions with my kids at home. Thankfully, it's only been volume at the moment, but that's good. Now, there's this, they say that, you don't know what's getting put in your body and all that, you've heard that. But is there any data or modelling on people who have actually had the disease, recovered, and what the modelling is long-term health, so that I can tell them, if you don't, this could be that the long-term, because there's this concern that the vaccine could cause long-term, no one knows, but that's got to be weighed up what the COVID disease would cause long-term. So is there any modelling, or, I know it's only been a couple of years, but on people that have recovered, are they being studied and monitored and...
That's an excellent question, and there's a lot of information. So first of all, particularly young women are very prone to get a long COVID syndrome, and we know that up to 50%, actually up to 60% of young women who will get COVID, acute COVID, irrespective of the severity of it, after 6 months will still be suffering symptoms such as headaches, fatigue, chest pains, a whole variety of symptoms. So that's correct. There's just been some really, I wish I'd brought it with me actually, but there's just been some very interesting information looking at people in general who have been hospitalised with COVID and what their outcome is. And I can summarise it by saying that the majority of them actually have got long-term consequences. Their health isn't as good a year later from what it was before they had it. So this virus is quite unusual. It has some really long-term consequences for people. Turning over to vaccines, there is not a single vaccine we know which has got any long-term side effects. If somebody knows one, I'd be happy to hear about it, because I'm not aware of one. Most vaccine side effects are acute. They happen early, anaphylaxis is the most extreme. You have an allergic reaction to one. People get sore arms, headaches and things like that. They're all common manifestations. And there are some vaccines which do have some earlier side effects. And these vaccines are no different. So we know, for instance, that Pfizer vaccine, the one we use here, has a tendency to cause inflammation around the heart, particularly in young men. But it happens in about 1 in 30,000 to 1 in 100,000 young men given the Pfizer vaccine. In the majority of people, it's after a second dose, and the majority it's very mild and they recover quickly. We know the AstraZeneca vaccine, which we don't use here, has a predisposition to cause a syndrome in which there's clotting inside the brain, particularly in young women. And again, that's about 1 in 100,000 to 1 in 500,000. So we know that. There was a big study done in Israel, again, in which they looked at roughly 1 million people who were vaccinated, and they compared it with 1 million people who were not vaccinated. Short term this was, a 100-day follow-up, and they looked at the consequences. And they found a slight excess of Bell's palsy in the vaccine group, and they found a slight excess of shingles, and they found a slight excess of, as I mentioned, clotting of inflammation around the heart. But they found dramatic reductions in just about everything else, because the people who were unvaccinated actually went on to get COVID and had major complications. At a mechanistic way, you wouldn't expect any long-term side effects from this vaccine. We're all full of messenger RNA. You know, all of us at the moment are making tons of it all the time. That's how our cells produce protein. If you want to make a protein for the blood system, albumin, the messenger RNA leaves the nucleus and goes into the cytoplasm of the cell and forms a template to make the protein. And then that messenger RNA is broken down. Otherwise, we'd all be awash with this messenger RNA. We'd just be full of it. It's actually a natural process of breaking down messenger RNA. It's got very short life. And it just makes a template for making the protein which is used to stimulate the immune system. The messenger RNA of this vaccine never enters the nucleus. It doesn't have the capacity to enter the nucleus. It cannot change our genetics long term. It's just simply impossible. It's simply a small fragment of the whole of the virus. If you actually get COVID, the COVID virus produces much more messenger RNA. It's it makes all its messenger RNA, and it makes, you know, and the cells which are infected with the COVID virus will just be full of messenger RNA from the virus. So I don't know if that helps to answer your question. Does anybody else want to have a go at that?
No, but I would just say that one fact that I remembered from Nikki Turner is that your chance of getting myocarditis with COVID is still 4 times higher than, you're 4 times more likely to get myocarditis with COVID than with the vaccine.
Oh yeah, much more, yeah. But there are lots of questions about concerns about long-term side effects. It's reasonable to ask that, but I just reiterate that most vaccines, I don't believe there's been any long-term side effects from any vaccines available. Some of the vaccines, like the live vaccines, MMR, they're actually live viruses, and they're producing, the virus is actually replicating inside our cells and making enormous amounts of messenger RNA, which makes, and that's to make the proteins which our immune system recognises. So what we're seeing here is actually normal physiology.
Hi, this is about children. I just noticed on your graph here that a lot of children actually caught COVID, and because in Christchurch we really haven't had it, last year of course there was some cases, but last year we didn't have grandchildren living in our house, so we've got grandchildren that live with us most of the time. The oldest one has just had a second dose of vaccine today, but the 2 others are too young. So my question is, when will the 10-year-olds or the 12-year-old and under be allowed to get a vaccination? Because they could bring it into our household. We're vaccinated, but they could still give it to us. They're in the schoolyard and all that, especially now that I want to call it the Tigers, but can I say that? The Tigers are coming to Christchurch.
Any context on that one, I think?
It's an in-joke, but anyway, that's my question.
There's a few parts to that. Alan has already asked about transmission between adult and children. We can talk about that. But in terms of, at the moment, so they're giving 5 to 11-year-olds mostly in the US, but in some of the other countries. But the main data that we're waiting for is from the US. I believe some of that data's gone already. So once MedSafe look at all of that data, then they will approve the vaccination, and that it's provisionally fine, that they think the benefits outweigh the risks. And once the MedSafe have said yes, the benefits outweigh the risks for 5 to 11s, then it will go to the technical advisory groups, and they'll decide whether they advise using it, and then it will go to the politicians, and they'll say whether they're going to do it. But they've already indicated that they want to do it by the end of January, although they're not back to school till February, so everyone is watching really carefully the data from America, and they're expecting it quite soon, to happen quite soon, if all goes well in America. Yeah. In terms of transmission from adults to children and children to adults, maybe do you want to? It's more common for adult to transmit to a child than for a child to transmit to an adult. I can't remember the exact percentages.
That's absolutely right. One of the sort of few challenges with this, and it's good to see what happens in America. First of all, children of between 5 and 11 rarely become sick with COVID. That's the first thing. So the very, very young babies can get sick. Under ones can get quite sick. But the 5 to 11-year-olds are usually asymptomatic. The biggest people that get really sick are older people and those who've got comorbidities.
I think in New South Wales it was 2% hospitalisations.
Yeah, much lower hospitalisations. And a lot of the hospitalisation for children are actually social hospitalisations because for various reasons. So that's the same experience in Auckland. And children are much less likely to transmit the virus. They will get it from adults. They don't tend to send it back. It's a whole pile of reasons for that. They lack the receptor for the virus, to be honest. So the virus is like it has a key, and the key has to go in a lock, and children lack that lock. They don't have that specific receptor, or they have less of it. So there's massive data from the UK and everywhere else showing that children rarely come to harm from COVID. And so there's still some doubt. There's quite a bit of worry about long COVID syndrome in children, but that doesn't seem to be such a big issue either. So that's why you might have heard one of our colleagues, Tony Walls, I've just mentioned this because he's been in the press, he's been on the television and things. Tony's one of the paediatricians here, and he has actually advised caution. He said exactly that. He said the young children rarely get sick. We should see what happens in America, and that's exactly what's happening. Waiting to see. There's no, sorry? Yeah, you far away.
I think one other thing is, I think you raised a good point just now in terms of children transmitting it to adults and getting adults sick. So one thing that wasn't in my sort of my conscience that much until I heard Tony's talk. I mean, when you look at the people discussing benefits and pros and cons of children getting the vaccine. One is, children should get the vaccine to protect the population, but then the cons is that they may experience more side effects than any benefit they may derive from it. So one of the things that wasn't in my conscience was that a lot of the vaccines for kids have never been given primarily just to protect everyone else, but it has to have a primary function of protecting them first before protecting someone else. It might have a secondary function of protecting the population. So is it the right thing to give it to them just to protect the rest of the population if their side effects are going to outweigh any benefits? We don't know. The FDA study is quite small, so I think that's why, as Claire was pointing out, we need to wait for more data in terms of whether there's more side effects or more benefits for the kids or not.
I was just thinking more that if they caught it, then they would have to be living with us, and then we'd all probably possibly catch it or have to live with it. It's not more about, I'm not too worried. Like I understand what you're saying, but the fact is that you're saying that they're not so likely to catch it.
And very unlikely to pass it on to us.
Exactly.
Less likely.
Yeah, substantially less. It depends what you look at. Tony actually showed us some slides suggesting that it never happens, pretty much. That children hardly ever transmit it to adults. It's usually the other way around.
I think in New South Wales, in the early childhood, there has been some occurrences of transferring.
It's happened, doesn't it? Yeah.
Yeah, but the other thing is it does depend on the context, and it is a numbers game. So the more transmission there is in the community, the more likely that children will be affected. So it will also depend a little bit on the context of how, if we have uncontrolled transmission, by nature there'll be more transmission. There's more likely it's going to affect children. So that is part of it as well.
And the vaccine does look safe in children, to be fair, you know.
Is it half dose or?
Yes, it's about a half dose. It might even be less than that, a third, is it? I think it's a third, yeah. Because the immune responses in children was better, actually. The trials showed that they mount a very, not surprisingly, you know, a child mounts a very vigorous immune response compared to somebody's 80, for instance. Yeah.
And it lasts longer.
Yeah. So some countries have decided just to give one dose to children. You know, there's a huge amount of variation around the world on this. Yeah.
My question you've kind of already touched on, but I wondered how COVID affected children, under 5 specifically, but I'm sure there's people here who would be interested in knowing about primary age children as well. But then my follow-up question, which I'll ask now because you've already touched on the former, is how as parents do we mitigate risk for our children?
This is Claire. Claire's the public health physician.
You can do the effect on the body.
So the evidence is that most children don't come to harm, as we mentioned, and there's an enormous amount of it. There's a little bit of variability, to be honest. In America, they've had a large number of children admitted to hospital. That hasn't happened elsewhere. And that might reflect the intensity of transmission, because they've got very intense transmission in America. And there's lots of social factors, you know. Some children get admitted to hospital because both the parents are sick, for instance, you know, all kinds of things like that. The worst outcome, fatality, is astonishingly uncommon, and I know that's the very tip of the iceberg, but in the whole of the UK, there have been less than 20 young children have died from COVID, and virtually all of those children have had some severe, it's terrible, but they've had some severe underlying health conditions. When you think of the 140-odd thousand people who've died, less than 20 have actually been children. So it's very much, it's not to say they don't get unwell, and they do get hospitalised, short of breath, and the usual thing, you know. Does that answer your question? Yeah.
Yeah, and the only place that I know that is Jim Russell, the paediatrician in Auckland, talks about is Texas, where they had just, again, a numbers situation where there was just so much uncontrolled transmission in Texas. There were children in hospital, but that doesn't seem to have happened elsewhere. In terms of, I guess it would be different if your child was vulnerable with underlying health conditions, but if they're over 12, then vaccination. Otherwise, it would be the same things that we know for adults in terms of them playing in well-ventilated spaces. Outside is obviously, we know, has been a lot less transmission in outdoor events than in indoor events, well-ventilated events, because we know it is airborne. So that's a really important thing. Coming up to summer, a lot of outdoor things are going to be the safest way to socialise. Some distancing is difficult for little kids. And same with the hand hygiene. The same we know for adults, really, but I'd say outdoor spaces and ventilation is probably the thing you could control for children, whereas hand hygiene, masking, vaccination for older children, they're all the main things.
Can I just ask, long term, because I'm presuming COVID is here to stay, is it good for children while they're young and less affected to actually get COVID and develop an immune response long term? I mean, was it better to get it while young or get it while older?
It's a great question. It's a great question. It's something that we...
Once upon a time, you used to put kids into bed and just get it through the family as quick as you could.
So nobody knows the answer. And that's the absolute truth. Nobody knows the answer. And only time will tell. And to be honest, it looks like New Zealand's going to vaccinate their young children. Many countries, I'm sure, will decide not to vaccinate the 5 to 12-year-olds. And it's a natural experiment, and we'll see. I'm just telling you the truth.
Sure.
We just don't know the outcome on that one. You know, most vaccines in children, just as James said, they get vaccinated to prevent really severe illness in young children. You know, measles, we know, kills young children. Look what happened in Samoa 3 years ago. You know, 90 babies, children died there. COVID doesn't appear to have that effect on young children. Obviously they get infected, some of them. Sometimes they get into hospital, they tend not to have bad outcomes. So, you know, there is a debate, and I can tell you that it was touch and go whether the US decided to go with that, because I followed the FDA discussion around it. And in the UK, the Advisory Council in the UK decided not to vaccinate children, but they got overridden by politicians. So it's a really difficult one. The key thing for protecting children really is to vaccinate adults. Claire said it. Adults are the ones who get sick. Adults are the ones who transmit it.
And maybe just reference to the up there for the under 12-year-olds. For all those who have been hospitalised in New Zealand with COVID, only 8.1% of those hospitalised were children, yet 23% of the children make up the total caseload of COVID.
So and all those children were infected at home, not in school. I think schools were shut, perhaps, I can't remember, but they were all infected in the household with adults who were infected.
Do you want us to mention about this?
Household transmission that's been the main driver of transmission from the Auckland outbreak, from the statistics, is from household transmission.
And do you want us to mention, so overseas, children in school, I mean, we're piling along together 5 days a week, 6 hours, is it worse to get, is it more likely to get transmission at home from adults or shed in the school?
From home, from adults, but in the school, is my understanding.
Yeah, by far it seems. Most children get infected from adults. All the data supports that. It's the teachers infecting the kids and the parents. Is that right, James? You want to?
Can I just say, so I am a Christian, background believer, and I just look at this. I'm taking a side step from the CDHB standpoint, and I've thought about this for a while. You know, the first big pandemic to hit the human race in a long time, and by God's grace, the kids are spared, isn't it? You know, I think it's you know, why? You know, chickenpox is something like that. Where so many other diseases, the kids do worse, much worse than the adults. But this is the first big pandemic in a long time, and by God's grace, you know, the kids are actually spared.
Yeah.
So.
Good way of putting it. Yeah.
Sorry.
No, I shouldn't say sorry. That's great.
That's
great.
I'll ask my supplementary first because you touched on it. Have the health professionals in New Zealand been overridden by politicians?
Is that a biological question?
Okay, I'll try this one. Am I right in believing that AstraZeneca is available to New Zealand in a very limited number? I think only mandated people. And of course that's a viral vector based, not a mRNA vaccine. So how do those two types of vaccines compare, and does AstraZeneca provide suitable protection from COVID?
So it's available to those over 18, and it is actually available to anyone who wants it. As a primary course, if you want to mix, and if they have what they call a mixed schedule, it does require a prescription. All primary courses require a discussion with a health professional, because Pfizer is the preferred vaccination in New Zealand and has got a slightly stronger safety profile and efficacy profile. There are some other side effects in AstraZeneca that need discussing. It is also important if somebody's had a severe allergic reaction, so an anaphylactic reaction to Pfizer, there may be a reason why they can't take Pfizer. That's why they've wanted to have options for people. The main thing to be aware of with AstraZeneca, the efficacy is almost as good as Pfizer. The side effect profile is a little bit different. There's something called, with blood clots where you get, and low platelets. So people who have a history of blood clotting, problems with low platelets, that is a risk for those people. And something where very, very rare, called capillary leak syndrome, those people should not have the AstraZeneca vaccine. So that's why everyone who's having the AstraZeneca vaccine under the age of 60 needs to have discussion with a health professional. I might just hand over to you. Something else.
No, that's about right. That's spot on, I think. The AstraZeneca is probably not quite as effective, and its risk profile is I mean, it's still a very effective vaccine, but it just isn't quite as effective. My mum had 2 doses of AstraZeneca back in Scotland, and you know, she's fine. She's just in a booster actually. She's in the 3rd, so it is an effective vaccine. It just probably isn't quite as effective, and it probably wanes a little bit faster. As you can see there, the yellow line, that's AstraZeneca AZ, and it's a different risk profile. It's not really suitable for younger women, mainly. I shouldn't say it's not suitable, but that's the group of people who have to have increased risk of side effects. Pfizer has paradoxically, Pfizer has this inflammatory thing around the heart in younger men. It's rare in both groups, really rare, but it does happen.
And overall, that MedSafe have deemed the benefits outweigh the risks at a population level. But it is worth having, people do need a discussion to check they don't fall into any of those categories where they'd be at higher risk. The other thing is that they currently don't have data on pregnancy and AstraZeneca, whereas they do for Pfizer.
Thank you. I want to say something quickly as well.
Yeah.
I finally get to speak. All I was going to say is that AstraZeneca is available only at certain locations within Christchurch, so that's Orchard Road, that's South City Mall, I think, remember correctly. Maui Clinic, yeah. Now, what I would recommend is if you are deciding whether or not you should go for AstraZeneca or Pfizer, to have a discussion with your GP. The GP sessions are free, so you wouldn't have to pay for that consult. So that is, because that is a barrier for some people, obviously. So that's just something I just wanted to flag out there. And then if you do decide that you do want the AstraZeneca, then you can get it prescribed then and there, and then you can just rock up to one of those sites to get your vaccine.
You only need a prescription for the mixed schedule. Yeah. If you're having 2 courses of AstraZeneca, you just need a discussion, you don't need a prescription.
Is more coming in? Because it was only 100,000, wasn't it?
I don't know. Does Amy know? Do you know if there's more coming in?
I don't know if there's more coming in. Alan, you probably know that I think only about 400 people were actually deemed like medically, only 400 people are allergic to having the Pfizer vaccine, is that right?
Even less than that,
even
actually.
Less than that, yeah.
Less than 100 people are thought not be able to have Pfizer in the country. I think it's an opportunity to nail one thing that you mentioned, Claire, that when you compare the risk of vaccine compared to the risk of COVID, so COVID has an overall mortality death rate of 1%. Okay, if you happen to be over 70, it's about 5 to 10%. If you're over 80, it's 20%. And if you're less than 20, it's 0.02%, or something low, but overall. Also, that's just the worst case scenario. About between 5 and 10% of people will be admitted to hospital, and a fair proportion of those, as I explained, will end up being very, very sick. And then the long-term consequences of COVID, as I mentioned as well, particularly for younger people, could be up to 50% if they've got long COVID syndrome, which is very debilitating. The vaccine, 1 in 100,000 people get the blood clot problem with AstraZeneca. In about 1 in 50,000 young men get the inflammatory thing around the heart, and it's around overall around about 1 in 100,000 or something, 100 maybe slightly less. And if you look at deaths due to vaccine, which a lot of people talk about, there's only been 1 death in New Zealand which has been even vaguely attributed to the vaccine. Now, quite a lot of people died after the vaccine, of course, because we vaccinate lots of people who just are going to die anyway. But just because somebody dies within a month or two of a vaccine doesn't mean it's due to that. You know, because you're vaccinated population. And what we know is that there's no excess mortality. There's no excess of deaths from the vaccine. Actually, if you look at and if anyone's interested, going to get the CARM report, which is the Centre for Centre for Adverse Reactions to Medicine, which is available publicly, and you read the whole thing, you'll actually find that the expected mortality in vaccinated people is somewhat less than what they expected compared to the normal population. And there has just been the 1 case in New Zealand that was thought to be related to the vaccine, and to be honest, there's quite considerable doubt about that case. We've talked about it, and it's uncommon. Yeah. So in comparison, if you stack the two up, there's no the vast advantage of vaccination compared to not being vaccinated. Yeah. Did you want to add anything to that? Yeah.
I'll just follow on from one of the points that Alan was making. So, you know, the vaccination not only prevents death, but also prevents hospitalization. And I think what a lot of places have seen is that, I think we had this problem slightly last year when we didn't really have a bad COVID outbreak, but we thought we had a COVID outbreak, was a lot of people didn't get the attention or medical care they needed or they deserved, because people weren't operating, cancer therapies fell behind, people weren't coming to seek help. And that's what is seen in a lot of other countries where there's a lot of COVID coming into the hospitals, they're taking up all the beds, and people with heart attacks, with other diseases, are not getting the care they want. So with vaccination, not only are we protecting ourselves, but we're also protecting and stopping spread, but we're also preserving the healthcare system or the beds for those who really, really need it. We have diseases which you can't predict or you can't prevent. You know, of course, you know, you get the vaccine, you might still get sick, you might end up in hospital, but the chances decrease, and you make all of that available to everyone else. And that's one of the things we've been preparing at the hospital, making sure we don't get overwhelmed. But we've only got that many doctors, that many nurses, that many beds. So, you know, if you can cut down the numbers of people coming in, other people can still get their surgeries, get their cancer care, etc. Is that right?
Absolutely, great point. There's one other weak thing I might just wanted to add as well, and there is, as somebody mentioned, there's a lot of information out there. And I want to talk about the health profession. There are about 30 doctors in New Zealand who are anti-vax, and they're quite public. 6,500 of us have signed a declaration supporting vaccine. So, 30 who are against or whatever, 6,500, and I imagine you've signed it. We said we have all signed the declaration.
Happy to publicly say that we have.
You can take one off today, because when I was in my granddaughter's injection today, I overheard someone saying she was a doctor and she was getting a first injection. So you can take one off. I don't know who it is, but
well, that's good. I'm glad.
Yeah.
So this is more of a risk assessment question. So
what kind?
More of a risk assessment question. So I'm not sure if you can answer it, but having the vaccine throughout the population reduces the spread, and it's obviously a very good thing in a population. When you're looking at assessing individual risk, is if you're looking at someone coming into your home or going somewhere, how do you assess, is there a kind of different risk between an unvaccinated person, a asymptomatic vaccinated person? So when we get to the point where it is in the community and you don't know who could or could not be infected, how do you make that kind of assessment?
It's difficult, but it is just we know that if someone is coming to your house and you know they're double vaccinated or they've had their booster, you know there's a reduced chance they're going to bring COVID into your house. I can't say by how much exactly, but it is less likely they're going to bring it to your house. But you're right to say that people become infectious before they become symptomatic, and some people don't. They're going to be transmitted less if they're asymptomatic, but we know people become infectious before they get symptoms, so you can't always just hope that tell people to stay away if they're sick. Obviously they should stay away if they're sick, but people can be infectious before they develop symptoms. But you're going to be at less risk in your household if people come to your house that are vaccinated. I don't know the proportion of how much.
Stuff at an article about a week ago suggesting 20-fold increased risk, 20-fold, and they did that on the basis that if somebody is unvaccinated, they are about 5-fold more likely to get infected. Now, to be fair, that does wane, as we can see here, but started at 25 and then dropped to 2, so that's actually 10-fold, and then. And James, actually, I'll let James speak to it, because you've looked at this, you looked at the whole issue recently about people who were vaccinated and unvaccinated and how infectious they were. Do you want to answer that? Yeah.
So there's a few studies out there which show that people who are vaccinated who get sick, either they can start off with less virus, or they may start off with the same amount of virus in their test, but the number of viruses die away much quicker. So they seem to be less contagious at the end of the day, or they become less contagious much faster. So there are various studies out there who show that. But in terms of, I think your question must relate to the fact that does the church do vaccine passport, or do we do the 50? Is that, I think that's what you're trying to get at, is that correct?
It is, but it's broader than just the church, because also we have children, so you have children's parents coming around, and we're not going to ask each person their vaccination status, but how do you assess that?
It's a big issue regarding, for a lot of New Zealanders, around Christmas, and some families making a stand that actually only vaccinated family come, which is obviously a different issue.
I think it's going to be very hard to tell. You may have someone who's already vaccinated, but may still be infected and have asymptomatic infection, and I'm sure there will be transmissions among even the vaccinated group. So I think vaccination is only one protection. We're looking at multiple layers of protection. We're talking about masking up, and also if you stay away, that's one other layer, and vaccination is just another layer. So it's not a foolproof thing to stop you from getting infection, but the good thing is that being vaccinated, number one, decreases the chance of passing it on, but also if you do get it, if you're vaccinated, it decreases the chance of getting very sick. So I think, it's not an absolute, it's multiple layers and relative increments of protection. Is that a good way to put it, I think?
I think that's pretty good. We have some evidence, information from Auckland Hospital, for instance, up north. So we've had patients arrive who were not thought to have COVID and subsequently found to have COVID and were in the middle of the wards, for instance, and you might well have heard of 50 staff were sent home from ED, etc., etc. Well, we've learned from a lot of that. We've learned, in fact, none of these staff acquired the infection from, it might be one or two, but hardly any of the staff that actually became infected. Now, they were all had as a minimum medical masks on, and the vast majority of them were vaccinated. Almost all of them were vaccinated. We'd all be vaccinated now, but because at the beginning. So we know that actually if you're vaccinated and you have a mask on, you're very unlikely to actually acquire the infection, in that situation at least. The other thing is that whilst people who are asymptomatic can definitely spread the virus, they're actually much less infectious. So I try to wind down the temperature a bit and say, if you're vaccinated and you're otherwise healthy, and somebody's coming to your house but they're not vaccinated but they're asymptomatic, the risks really are very, very low. The other thing is local epidemiology is really important, and we very rarely hear about that. But you know, at the moment, there is no circulating COVID in Christchurch. We can say that pretty confidently on the basis of our sewer water testing and various other things, you know. So there isn't none. Now, things might well change, you know, on the 15th of December when we start to get some visitors. But we don't anticipate that we're going to see massive surges of infection. I know you've heard that, but we actually believe our vaccination rates are so high. You know, we're 88% doubly vaccinated population over the age of 12. If you go to the over 50s, we are something like 95% doubly vaccinated. So just the sheer amount of vaccination, we're ahead of the curve. In fact, we've started doing boosters before we even have any COVID. So actually, we're really fortunate that we're ahead of the curve. We've learned so much from overseas. And so I don't really think we need to be, I'll use the word paranoid, it's maybe too strong a word, but I don't think we need to be too obsessive about the whole thing, you know? That, you know, and certainly in a situation where there's very little transmission in the community, you know, very unlikely somebody's going to bring it into your home. If it's somebody you know, and especially if you're vaccinated, you're very unlikely to come to harm. Does that answer your question?
I was hoping that would be the answer.
Yes. It's a long-winded. You know, what we do in the hospital, and I'll just say this, we always talk about epidemiology. You know, the hospital here in Christchurch has been operating in green throughout all of this. South Island's going to orange, and you know, but yeah, it's going to orange, but we will remain a green hospital.
Yeah, so I suppose context is important, and your answer might change if we're in a different. If Christchurch is in the middle of a large outbreak, but while Christchurch is not in a large outbreak, you might have a different take on it.
But we're fortunate because we've got such high vaccine levels, so we are reaping the reward of having high vaccine levels. You know, that's because all the good work that people have done. Yeah. Like Satish here, you know.
Do you feel like
Go for it. Got a loosely connected supplementary. You mentioned mask use a lot, and there's been a lot of articles recently about the effectiveness of different types of masks. So any advice?
I'm doing too much talking. I'm going to hand over to somebody else.
Well, I would just reiterate what Alan said in the experience of Middlemore Hospital, that mask use plus double vaccination was really, really effective. I do know that medical masks are slightly more effective than cloth masks, but again, what Alan said, context is important, so it depends on your setting. If you're working in a healthcare facility, or are you just going to a talk at something like this.
I'm going to say this because I have to. This mask can be washed by hand 10 times and remains effective. And our great colleague up in Nelson demonstrated that and did the experiments himself, Richard.
And this is your standard El Cheapo from the...
Well, no, this is a hospital one, but
it's a hospital medical mask.
Yeah.
So a few weeks ago, when my son had his birthday, my daughter had her birthday, we took her onto the Waiwa River on a speedboat, and the guy said, "We don't need to wear a mask. The airflow is so good because you're on a speedboat." And that's just an extreme example. So I think when we were talking about masks, the transmission happens. If you look at all the media and all the reports, transmission has happened in closed spaces. So like big Korean church, the ship. And in closed spaces where there's no airflow. If you're out running on the football field with your friends and there's good wind blowing, I think transmission is less likely. So you don't need to wear a mask if you're out having a rugby game, I don't think.
There's actually very little evidence of outdoor transmission. It's virtually all confined spaces indoors.
And do you want to talk to, last year it was about wash every surface and all that contact transmission, but this is since then an aerosol virus, so if someone had COVID this afternoon using that table,
No worries.
writing, and you're in it tonight. Like how worried should we be about surfaces?
Do you want to do it?
Yeah. Well, I was involved in a lot of looking at the clusters of working out that the only way some of the people from the hotel isolation facilities could have infected other people was through airflow. And actually, again, in enclosed spaces, in corridors, and to do with the pressure. When they open the doors, the air gets sucked out into the corridors. So that's how they worked that out, as well as thinking about other respiratory pathogens like tuberculosis. It's a lot slower, but it's also an airborne respiratory pathogen. So they did a lot of science and re-evaluated that. And now we're much less worried. You still should wash your hands, and also for other foodborne, fecal, oral, for other hand hygiene reasons, you should wash your hands. But we're much more likely from breathing in each other's shared air. So now what we're calling shared air. So if you're sharing air with someone, that's much more important than if you've touched the PIN code on a, everyone does PayWave anyway, don't they?
Good one, Alex.
In regards to testing to see if someone is infected with the virus, my understanding it takes about 1 to 2 days to get the results at the moment. Is there any plans to try and find a faster method, or is there any benefit? I'm assuming there is a benefit. The sooner you catch it, the better.
Yes, they have announced publicly that they are going to be using some point of care antigen testing, which what they've been using in the UK for quite a long time now. People do these rapid tests. They look a bit like pregnancy tests. People do a little swab and then they put the little kit together and they get a result straight away. They've publicly announced they're going to be available. I don't know when they're going to be available. And the reason is because they're not quite as effective as the PCR test you go in when you have the big swab deep into the nose. But when we're in an elimination strategy, if we miss any one case, that's actually disastrous for the elimination strategy. In a suppression strategy, we just want people to be being tested as much as possible and as quickly as possible. And if they're pretty accurate, that's good enough.
I do need to add something though. The tests are actually probably of no value unless somebody's symptomatic.
Oh yes, sorry.
Yeah. Okay, so they're much less sensitive than the standard PCR test unless somebody's actually got symptoms. Yeah. Whereas the PCR test will, is incredibly sensitive. So if somebody's got symptoms, they're about 80% sensitive. If somebody's if they've got minor symptoms, they're about 50%. So there's some real problems with. There's still a debate, to be honest, about their use.
That's why you can't use them in elimination strategy.
Yeah. There's also So there's still a pretty active debate about their value, from that point, where their place is. And anyway, probably not add much more. The part of the delay in the PCR test, actually the lab here is incredibly good, and the lab does the PCR testing in about 12 hours. Often the delay is actually getting the result. If you actually go to, and Satish, you're the expert here, if people go along to one of the testing centres, then they're booked actually electronically, and the results come back much faster. The problem is often if somebody goes to the GP, and they the slow, it's snail mail for the result to get back, isn't it?
Yeah.
You probably should talk to this.
I'll talk a little bit. So Alan, that is quite a good summary. If you were to go to Orchard Road, 174 Orchard Road Testing Centre, because 100D Orchard Road is the vaccination centre. And the other place to go to is the Marae, Nahuifa. Again, the testing centre. There's also a vaccination centre located there. Because it's now electronic with barcode, you're likely to get the the test result within 24 hours. What we're finding with general practice, or when you see, is that there's just literally a delay in the result. The lab actually, the Christchurch lab is actually quite quick, and they can churn out a result. If we send a swab in the morning, you can get it back just before 24 hours. But the issue is that result, by the time the GP sees it, processes it and thinks, well, what do I do with it? There is a bit of a delay, but so it might be like 2 days by the time you get your result back from your GP. I mean, if it is positive, my understanding is that the Christchurch lab team do immediately notify public health to say it is positive. Yeah. So if it's positive, you definitely would get a result back in 24 hours. But for, I don't know, pre-departure testing and whatnot, I would highly recommend, I don't think Orchard Road is actually doing payment for that at the moment. I think the best way to do pre-departure testing is
fit to fly doctors.
Fit to fly doctors. Sorry, I'm a bit out of the loop with testing now, but that is generally the case. Does that answer?
I think the main thing to say is that we're quite lucky in Christchurch that they can do them quite fast.
Yeah. Auckland, it can take up to 5 days.
Wow. They're usually less than 48 hours in Christchurch, so I wouldn't worry too much about the delay. They're pretty good here.
And Satish says, if it's positive, you'll hear within 24 hours. We don't sit in positive results, the lab responds immediately.
Probably a last question, I think.
I guess my question's probably a question I could ask my GP. So the first vaccine I didn't have any adverse reaction to, the second one I did. And it was probably about 3.5 hours later my heart was increasing in beats.
Yep.
So I guess it puts me at the fear of, I understand the boost is really important, but if you get dose after dose, is the third dose worse than the second dose, or am I, I know that's a hard question, but it puts the fear in me thinking, oh God, what the, yeah.
Do you want to talk about?
Yeah. My understanding is that for Pfizer, the booster doses at 6 months later haven't been any particularly different side effect. The proportion of people with side effects is similar to the second dose. Remember, it's 6 months later, not 3 to 6 weeks later, so that changes things. You've got a different. It's not like you're just piling them on in short space of time. So my understanding is that hasn't been increased, but I think it is still, boosters are still quite new, so there is still data being collected.
I'll let you know tomorrow.
Maybe just to wrap up, for most of us here, I'm sure prior to COVID, we didn't really have much knowledge about viruses in general. We just knew about the main ones and your jabs for kids, and now it's sort of, it's all under the spotlight in terms of viruses and vaccines. Maybe can you just explain comparatively? So we're familiar with flu. Still hundreds of people die of flu each year or related to that. So when you compare the COVID outbreak in New Zealand to influenza in New Zealand, can you help us with that through a comparison of what is the difference, and where should people be a bit more worried or cautious, and for those who are naturally very, very cautious, can you give us a guide using that comparison?
I think when the outbreak first started last year, definitely we saw that the harm coming from COVID was higher than influenza, so it was a worse virus than influenza. But the vaccines changed that landscape dramatically, isn't it? But I don't know how it compares now. I haven't looked at the stats recently, but it's made it much less harm for people to come from it. Do you have the numbers?
The vaccine effectively, we talked a lot about vaccine effectiveness. The vaccine effectively knocks 20 years off your life. I wish it did. From the point of view of risk from COVID. So So the risk now from COVID, after if you're vaccinated, the risk is probably comparable to the risk of flu. So COVID, if you're unvaccinated, is much, much higher risk than flu. People go on about it's being the same as flu. That's not true. You know, in Italy, if you're over 80, you've 1/3 of the people died. That doesn't happen with flu. It's maybe 3%, not 30%. So COVID is at least 10-fold, probably up to 100-fold more severe outcome than standard flu. You know, pandemic flu, such as the Spanish flu and things, were much, much worse. So, yeah, James is right, really. I think that flu is much less severe overall than COVID. And the other thing is that flu does not have anything like the long-term consequences. You know, most people here have flu. I've had flu a few times, and I felt terrible for a week or two, but I recovered. I wasn't debilitated for months.
Very good. Well, that is super helpful.
No.
Thank you again for your time. I'm sure I speak on behalf of everybody that is so helpful, rather than us clicking through the internet trying to find bits and pieces and finding lots of bits and pieces. It's so good to have what you've shared. Did you want to?
Yeah, I was just going to say that it is important to what sites you are clicking on. You all know that, but it also has, on Unite Against COVID, has a page about how to recognise misinformation. But also Pastor Nigel, we can tell him what sites are really good, so which ones have been the scientists have contributed to. So just be really careful of what you're looking at.
Sure. No, I appreciate that.
Yeah. Just to add to that, just because it says something and this person's an expert, there's one going around, this guy is claiming to have been the father of the COVID, of messenger RNA, and he was a scientist, it's true, who was involved in the discovery of messenger RNA, but if you delve into it, you'll find that that's not the full story. Yeah, I won't go on too much, but you know, there is a reason why the vast bulk of doctors and scientists support vaccination. There's a reason.
Very good. Well, should we give a round of applause?